recording. This is Dr. Russell Brown. We are here this morning for another case review. Um, this morning we will be talking about schizoaffective disorder. Um, the textbooks that we will be using are Psychiatric Case Studies for Advanced Practice by Kathleen M. Prendergast and Casey Jackman. Um, and this is the I believe this is the first edition of the book. I'll go ahead and just present the case study or present the case, and then you can ask questions along the way. But then we'll go ahead and break the case down, diagnosis and treatment. So um, this is case number 38. The name of the case is telepsychiatry. Uh, and the main diagnoses here will be schizoaffective disorder with a secondary diagnosis of panic disorder. Um, anyway, on as far as identification, we have um, a 35-year-old Caucasian, English-speaking, married male on permanent disability. He lives with his wife and his three children, and he is being treated via telepsychiatry. His chief complaint is I've been having a lot of trouble with paranoia and anxiety. Um, the patient has been in treatment at a community mental health agency continuously for the past several years. His primary complaints are auditory hallucinations, paranoia, as well as anxiety. The voices he hears tell him that he's worthless. They become more intense when he's alone. Uh, they bother him almost constantly to the point that his wife can tell that he's not present in the conversation with her. Um, he's responding to that internal stimuli. He attempts to participate in the school activities of his children, but admits that he can never stay for a full program because the voices tell him that someone is going to hurt him. He has terrifying nightmares. The hallucinations and the accompanying paranoia cause fears that others are always talking about him, or that his children may get hurt. These fears precipitate panic attacks with rapid heart rate, difficulty breathing, tingling in his hands and feet, upset stomach, and sweating. Due to the panic and fears, he often isolates himself. He also describes panic symptoms that are not triggered by any voices or any precipitants at all. However, he's trying to manage his anxiety by healthy activities such as walking over a mile a day. As far as his past psychiatric history, at the age of 9, he was hospitalized for some behavior problems. He reports that he had dyslexia, uh, attentional deficit problems, and explosiveness as a child. He's been to juvenile treatment centers. He has a history of suicide attempts at the age of 11 through an overdose. Um, at the age of 12, uh, um, uh, he also tried to harm himself with a shotgun. He also had a history of cutting behaviors. The first auditory hallucinations occurred when he was around 17. From 17, he engaged heavily in drug use, including methamphetamines, heroin, cocaine, marijuana, and alcohol. He stopped using all these substances at the age of 25 when he almost died from an overdose. He was engaged in psychotherapy for some time. He also received pharmacological treatment. The psychotropic medications have included lorazepam, Buspar, Safras, lithium carbonate, Seroquel, and Ativan. In the past 2 years, he has had two episodes of mania lasting for 2 to 3 days, spaced about 6 months apart. Um, uh, His current medications are lithium carbonate, ER, 300 milligrams in the morning and 900 milligrams at night, Seroquel, 300 milligrams at night and 50 milligrams BID, Ativan, 1 milligram 3 times a day, PRN for anxiety, and a medicine called Silenor, Silenor, 3 milligrams at bedtime. And this is a doxepin. As far as his medical history, he has no known allergies. He's he has diabetes type 1 with diabetic neuropathy, elevated liver enzymes, hyperlipidemia, hypertension. He has non organic sleep apnea and osteoarthritis. His most recent hemoglobin A1C was 8.7, which is high. His weight is 304 pounds. His body mass index is 37.5. While taking Zyprexa and then Saffris, his liver enzymes were elevated. Um, uh, his liver enzymes now are normal. Um, and I think he's just on the Seroquel. Uh, he's taking carvedilol 3.125 milligrams BID, Humalog, QuickPen 25 units before meals, Lantus Solastar 68 units at bedtime, uh, atorvastatin 20 milligrams every day, lisinopril 2.5 milligrams daily, metformin 1,000 milligrams BID, Profair HVA 108, 2 puffs every 4 hours PRN. He's also recently started Orlistat 120 milligrams a day. Uh, so he has some serious, medical problems, high blood pressure, hyperlipidemia, as well as diabetes. His sleep pattern has improved from only 3 to 4 hours at night now to 5 to 7 hours with the use of the doxepin. Let's look at his drug history real quick. He has a history of drug or he has a well, he was a former cigarette smoker. He reports heavy drug and alcohol use from the age of 17 to 25. Um, he stopped because he had a near-death experience. He acknowledges that his use was a form of self-medication for the hallucinations that he was having. He states, I used everything and anything and everything, methamphetamines, heroin, cocaine, pot, alcohol, to self-medicate. He states that he almost died at age 25 from overuse, which is what led to his decision to stop using. He has not used substances since that time. He no longer drinks alcohol due to the impact of his blood sugar. Uh, he achieved sobriety through participation in AA and the support of his church. As far as his family history, the patient does not know if his biologic heritage includes any mental illness. He states that during his childhood, his father was very violent and abusive, angry and yelling and throwing objects all the time. His father never received any formal diagnosis or treatment. His parents are still alive and married to each other, but the relationship is characterized by bitterness and constant fighting. The patient often feels pulled into the conflict and forced to take sides with his parents. He does have 2 brothers and 1 sister. He feels closer to his sister. As far as his personal history, uh, perinatal, he had no known complications. As a child, he was able to make friends and function academically well in school. He had no known learning disabilities, but he does report uh, a self-report dyslexia and attention deficit. He was as an adolescent, he was able to complete high school. In adulthood, after high school, he left his family. He moved out of state. He was in the army briefly and was released due to mental health issues. so they must have been significant. He was married at age 20, and this ended up in divorce with one child. He has been with his current spouse now for 10 years. They have two children. His child from his first marriage also lives with him. He's currently on disability. He lives in an area that is underserved by psychiatric providers, so he is being treated by telemedicine. As far as the trauma and abuse history, the patient experienced abuse at the hands of his dad. He does not elaborate on the details, other than to say his own anger scares him because he does not want his children to go through what he went through or experienced. Now let's move on to his mental status. Appearance, he's neat and clean, appropriately dressed. Behavior and psychomotor activity, he's cooperative and pleasant. Uh, Posture is upright. Consciousness, he's alert and oriented person, times three. Memory appears to be intact. Concentration and attention, he's able to do some simple arithmetic and spell the word world backwards. Visual spatial ability, he can draw a clock face and put indicate the stated time. Abstract thought, he's able to accurately explain proverbs, uh, such as people who live in glass houses shouldn't throw stones. He can explain that. Intellectual functioning, his vocabulary is average, and his funded knowledge is fair. Speech and language is good volume, normal tone, perceptions. Um, he does have auditory hallucinations, so the voice is telling him that he's worthless, but he has no visual hallucinations. His thought processes are clear and linear. Thought content. He does have frequent intrusive thoughts that other people are against him. Suicidality, and homicidality. He has no thoughts, intentions, or plans to hurt himself or others. Um, and he was evaluated doing using the violence risk screening tool. Um, um, with his current presentation, he was considered to be at low risk due to the criteria in this violence risk screening tool. Although he does not have a major, although he does have a major mental illness, there was no previous or current history of violence, threats, personality disorder, lack of insight, lack of empathy, unrealistic planning, or imminent expectation of unusual stress that might increase the potential for violence. Although there's a history of substance abuse, um, there's not been any use in the past 10 years. He does not have access to weapons, and he is very insightful and motivated to continue his treatment and utilize healthy coping skill mechanisms. So, based upon those um, um, properties, he was considered to be low violence risk. His mood is generally somber. Uh, Affect is pleasant. Yet there's some blunting going on. Impulse control is good. Judgment, insight, reliability is fair. The patient's aware that he lives with a chronic mental illness and actively struggles to adjust to it. He works hard to stay active and involved with his kids, um, giving his limitations. He does seek out the company and support of his wife, stating at time he just needs to curl up beside her when the voices are intense. He does keep all of his appointments and reports 100% compliance with his medication. So now we've gone through the history and examination. So we need to come to impression and plan. Um, so we need to formulate a diagnosis for this guy, uh, and which diagnoses should be considered. Uh, at this point, we have two top diagnoses: schizoaffective disorder bipolar type continuous, and panic disorder. Um, does anybody have any questions before I dive into the diagnostic formulation? I
No.
don't. Uh huh. Go ahead.
No, I said no, I don't.
All right then. Good. All right then. So let's look at the schizoaffective disorder bipolar type. All right. The diagnostic criteria for schizoaffective is an uninterrupted period of illness during which there is a major mood episode, major depression, or mania concurrent with criteria A of schizophrenia. Um, uh, B, the delusions or hallucinations. Uh, there must be delusions or hallucinations for 2 or more weeks in the absence of any major mood episode, depression, or manic during the phase of the illness, and the symptoms must meet criteria for major mood disorder are present for the majority of the duration of the active and residual portions of the illness, and the disturbance is not attributable to any substance um, um, uh, uh, or drug of abuse. So basically, in order to have the schizoaffective disorder, you must have period of psychosis, delusions or hallucinations for more than 2 weeks in the absence of any major mood disorder, and that would be depression or mania. But you you also must have depression or mania during some course of the illness concurrent with the psychosis. And at times you may just the psychosis may abate, and then you just have uh, evidence of a mood disorder, mania, or depression. So the episodes where they run concurrent, and there are times when the psychosis just goes on unabated for at least 2 weeks, and this would distinguish them from uh, bipolar disorder, mania with psychosis, or major depressive disorder with psychosis. In those last two situations, when you got rid of the mood disorder, typically the psychotic episode would abate with the treatment of the mood disorder. In schizoaffective disorder, if the psychosis goes away, the mood problems may continue, or um, if the mood problems are treated, the psychosis continues. So, what is the rationale for this diagnosis of schizoaffective affective disorder? Um, in this particular patient, the client fulfills criteria for the diagnosis because he has a continuous experience over more than 15 years of delusions of being in danger from others and of having these auditory hallucinations. Um, Although he has not exhibited any disorganized speech or grossly abnormal physical behavior such as catatonia, he does have some negative symptoms with the reduced facial expressivity and his vocalizations kind of being blunted. These have occurred concurrently more times than not in the presence of major depressive symptoms such as depressed mood, sadness, loss of interest, feeling guilty, worthless, diminished energy, and insomnia. And he has also had at least two self reported episodes of mania with flight of ideas, pressured speech, and a diminished need for sleep. Now, I don't know if these episodes of mania occurred when he was not using drugs, but I would assume that they were because we have a diagnosis of schizoaffective disorder, uh, bipolar type. Um, does anybody have any questions about that particular diagnosis? Why we established it? Anybody would feels that that needs to be challenged, that diagnosis, based upon the history and exam. Okay, if not, then we'll go on to the secondary diagnosis, which is panic disorder. Um, Panic disorder is defined by recurrent, unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time several symptoms occur. You can have palpitations, sweating, trembling, shortness of breath, feelings of choking, chest pain, nausea, or abdominal distress, feeling dizzy, chills or heat sensations, paresthesias, which is numbness or tingling sensations, derealizations, derealization, feelings of unreality or depersonalization, a feeling of being detached and looking over oneself, or a fear of losing control or going crazy or fear of dying. Um, these attacks generally have been followed by a month of persistent worry and some maladaptive change in your behavior. Uh, what is the rationale for this diagnosis of panic disorder? Um, this diagnosis might be questionable based on the fact that it's the result um, um, of him having the hallucinations uh, and the delusions. Um, the patient's panic often has been precipitated by the fear generated by his delusional beliefs. However, he also reports episodes of panic where he was in a relatively calm state of mind in a safe place, and he still experienced some of the symptoms that I just read out. He does worry about repeated attacks and has resorted to staying home and avoiding being around other people. Therefore, the diagnosis of panic disorder is indicated. So, I mean, the take home point here is that uh, panic disorders are spontaneous, they come out of the blue, they're not triggered. Um, if they are, then you have to label them as some other type of anxiety disorder, of a specific phobia or social anxiety disorder. But because he has these panic events without any triggers, he will be his these behaviors will be labeled as panic disorder. Uh, Anybody have any question about that diagnosis of panic disorder and how it was established? Alrighty. Um, what tests or tools should be considered to help identify the correct diagnosis? Uh, I don't think we really need to use too many tests or structured instruments, but the text here suggests using the World Health Organization Disability Assessment Schedule 2. People commonly use the BPRS, the Brief Psychiatric Rating Scale. There's also the Positive and Negative Syndrome Scale for his psychotic symptoms, and there's also the Calgary Depression Scale for schizophrenia. Um, the CDSS, the scale takes the psychosis into account when assessing the level of depression. The other scales for depression, Hamilton Depression Index, the Beck Depression Scale, um, were developed for cases where people did not have psychosis. So they recommend the Calgary Depression Scale for schizophrenia in this case. Um, what differential diagnosis should be considered in this case? got several things that we would need to think about. The major depression with psychotic features, uh, bipolar disorder with psychotic features, and agoraphobia. As far as MDD with psychosis, the depressive symptoms in this client have waxed and waned over time, but the psychotic features have been a constant presence. Thus, major depression has not been the primary diagnosis. So, does anybody have any comments about that? Once again, um, he has been depressed, it's waxed and waned, but when the depression has remitted, the psychotic symptoms here have continued, the auditory hallucinations and the delusions. As far as the bipolar disorder with psychotic features, on the differential, although the client did experience 2 episodes of mania, he has had persistent delusions unrelated to the episodes of mania. So, once again, he's had these manic episodes that are self reported. I think he said they lasted 3 days apiece. I'm not sure if that would really qualify for mania, and he may also have been using some substances. But anyway, when those episodes abated, uh, his psychosis still continued. As far as the agoraphobia, agoraphobia might be considered. However, the client's discomfort around other people seems to be due more to the hallucinations telling him that the other people are against him and are going to harm him. So they're not just an abnormal fear coming out of the blue. Uh, he his isolation is more related to him responding to his actual thought content. Um, any questions about the differential diagnosis and why they don't make it to the level of being uh, diagnoses, active diagnoses? Alrighty.
All right.
Um, Now let's formulate a treatment strategy. So, what treatment would you prescribe for this patient, or what medications, and what is the rationale? Um, Here's a note here. Due to the overlapping symptomatology between schizophrenia and schizoaffective disorder, uh, many treatments for schizophrenia um, will also benefit patients with schizoaffective disorder. So really, the same medicines or the same strategy that we use in schizophrenia, you'd use in schizoaffective disorder. Pharmacology, continue the current medications. He's on lithium ER, 300 milligrams in the morning and 900 milligrams at bedtime for a total of 1,200 milligrams a day. This medication is the gold standard for mood stabilization um, uh, in mania and was started several years ago when the patient experienced a manic episode. So that must have been some significant event if they treated it. The dose has been adjusted several times, and the client reports that he's feeling stable with no breakthrough um, manic events, and obviously he's not having too many any side effects to the lithium. He's also in Seroquel, 300 milligrams at night and 50 milligrams twice a day. Uh, Seroquel is the second generation antipsychotic medication that's approved by the FDA for the treatment of schizophrenia and bipolar disorder. Other second generation medications have been tried and were not effective, or they were not covered by its insurance, um, or there were significant adverse effects, such as elevated LFTs with the Zyprexa and Saffris. He states that although the voices are still present, they are far more manageable than they've been in the past. He has gained weight and that is monitored carefully. He states that his current combination of medications uh, has allowed him the highest level of functioning he's experienced in many years, and he does not want any further changes or adjustments at this time. So, given this guy's history of weighing 304 pounds, um, having hyperlipidemia and diabetes, uh, would y'all still keep him on the Seroquel, or would y'all kind of push him to bump off of that, even though he feels other things have been tried? Is there anything else out here that we could look at instead of the Seroquel? Do you think would Abilify be useful?
Yes.
Right now, I don't know if Abilify, off the top of my head, if it does have an indication in bipolar. I can't. I don't know. I didn't look that up, but he is already on the lithium. And I
Mhm.
guess what you're trying to do now is just deal with the psychosis. Um, my thought would, Seroquel isn't like the most potent drug, and Abilify would do just as well because of his diabetes um, and his significant weight. I I may recommend using something else. Are
What
Yeah,
there?
we
about
can use
Vraylar, Dr.
Abilify.
Brown?
Abilify is FDA approved.
What's that? Oh,
We can use Abilify. I use Abilify for bipolar disorder patients because it is approved for that as well.
all right. Good, good, good. Someone else was
What
about to
about
say,
Vraylar, Dr. Brown?
yeah, yeah. Does does that have a better side effect profile as far as um, the weight gain, glucose intolerance?
Yes.
Yep. So I switch him over to that. And granted, this book probably was written before Valar was out, so there are probably a lot of new agents that we can use. But I just want to get y'all to list some of the other agents that y'all would try. Some of the newer agents. So Valar, Abilify, anything else out there that we could get this guy off of the Seroquel, so his weight and glucose intolerance would improve a little bit.
Is he just taking the Seroquel for sleep, or what is he taking it for?
I think he's taking it for his psychosis. The voices he has this continuous voice that he hears that tells him negative things about his family, about him,
Mm.
his kids, uh, and people just talking about him. And it doesn't seem to be an internal voice that you would experience with depression. It's uh, it's an active voice uh, conversating about him. So,
I would probably
all
try
right,
the Vraylar because of his
available.
weight, and then
All right,
for let's see if that would help with the psychosis.
gotcha. All right. Anybody have any other ideas? That's about it. That's where we're at with Valar and Abilify.
Or Latuda. Latuda doesn't have as much weight gain as neither. Um, and then eventually like a long acting, which would be like Abilify.
Uh huh. All righty. All right. All right, that's good. Lorazepam, 1 milligram up to 3 times a day if needed for anxiety, for his panic. Ativan is indicated for the management of anxiety disorders or for short-term relief of the symptoms of anxiety. Although antidepressants are typically the first line treatments for anxiety, they may precipitate a manic episode in someone with bipolar disorder. I know that the benzos could disinhibit you. I never knew that they were associated with generating mania. Um, with benzodiazepines, there is a potential for dependence, particularly with long term use. The risk needs to be weighed against the benefits for which the treatment is being provided. Because the patient's anxiety significantly impairs his functioning, the use of lorazepam is clinically indicated. Um, would y'all keep him on the Ativan 1 milligram TID, or is there another anti-anxiety medication that that uh, and I made the wrong statement. They didn't want to put him on an antidepressant for the anxiety because the antidepressant would generate the mania, not the Ativan itself. So let me correct that statement. So obviously we can't use an antidepressant in this guy because we may swing him into the manic episode that he's self-reported. So are there any other agents that we could use to manage his anxiety? Or is everybody cool with Ativan TID on a PRN basis?
No, I would use something else because of his history of the substance as well. And the benzo should be used short term. I would use like Boost Bar, even some Visceral. Um,
Hmm. All right. Yeah. And I don't know if there's a concern that that the serotonergic activity of those medicines may prompt a mania, but those are considerations. I was thinking I would just use a long term agent like Clonopin, maybe 0.5 milligrams once a day or twice a day. Uh, the only thing is, this is a big guy. He weighs 304 pounds. Um, you know, um, he does. He doesn't get that much sleep, and I don't know if it's because he may have sleep apnea or something like that. So you just got to be concerned about respiratory depression on a long-acting benzo like that. But Klonopin does have some anti-manic properties, um, and so I would consider that. Uh, Anybody else have any other ideas about how to deal with uh, this panic disorder other than using Ativan as needed? I think Ativan is an okay option in Buspar, Vistaril. Anything else? Clonopin. All right. We have Silinar. I never heard of that before, but it's actually Doxepin uh, at bedtime for the insomnia. Doxepin is recently marketed brand name for older tricyclic antidepressant, which is Doxepin. Um, um, at this low dose, there's minimal danger of kindling or pushing the client into mania. So um, I'm sure there's some other things that we could use for insomnia at this point. I mean, I would even consider putting him on some melatonin. Is there anything uh, anybody else would want to try to help him sleep, get some rest, and even getting sleep? A normal amount of sleep has an anti-manic, antidepressant effect. So helping him with sleep would be beneficial. Uh, Anything? Is there any other agent someone would use to help him with the sleep? Nothing else.
What about
All right.
what about some what about magnesium?
Yeah, I mean, people do use that. I mean, I wouldn't be against it, but you could try it and see if that helps him rest. You know, yeah, that's an idea. Um, All right, let's look at some of the diagnostic tests that he needs to have, some of the labs. He needs to get a BMI at every visit with a waist circumference at the start and then annually. Abnormal Ames test to detect any abnormal involuntary movements, akathisia or EPS from the antipsychotics. Um, he needs a fasting plasma glucose at the start and at 12 weeks, and then annually if he has no abnormal readings. Um, Fasting lipid profile baseline, then at 12 weeks, and then every 5 years if no abnormal readings. I don't know if every 5 years is a reasonable period, but that's what the text suggests. He needs to get a lithium level, TSH, creatinine at week one, um, and then 1 to 2 months, and then every 12 months if there are no abnormal readings or after any dose alteration. He needs to get a drug screening random to monitor his use of the Ativan to make sure he's using it and to rule out any illicit drug use. He should be referred out for psychotherapy, and this can be supportive. This therapy focuses on the therapeutic bond between the client and the provider, um, with the provider responding to whatever the client presents at any given session in a way that's affirming and empowering. There's also ACT, um, which is acceptance and community therapy, and this has been used in clients with schizophrenia, chronic psychosis. There should be some psychoeducation. The patient should be educated about the symptoms of lithium toxicity and instructed contact the provider or the clinic to be evaluated promptly if there's any abnormalities. The patient should also be educated about the metabolic side effects of the second generation antipsychotic medications. He should be given information on he should be given information on schizophrenia from NAMI or any other resource, NIH. And I think we talked about that in our last case review session, making sure we can get the patients or their caregivers some information on their diagnosis and the medications that they're being prescribed. Um, so they can recognize if the meds aren't working, what the symptoms are, as well as any side of or adverse effects with the medications. Um, there are guidelines that we can go um, to help us in our establishing treatment plan. Um, the ones I go to generally from the American Psychiatric Association, they have a whole book on every diagnosis and standard guidelines that they update if if things aren't working. Um, so, any questions about psychoeducation guidelines, the type of psychotherapy that would be used, or the patient should be referred out to? All righty. Well, let's just go over some quick clinical notes. Medications used to treat schizophrenia carry um, high side effect profiles. You know, you must monitor the metabolic side effects, especially of the second generation antipsychotics, including the hypertension, hyperlipidemia, elevated blood sugars, uh, and increased weight. It's important to address these metabolic issues because studies show that patients with serious chronic mental illness have a short life expectancy by 25 years. So, with or without the medication, they're gonna have a short lifespan. So whether you don't put them on meds or whether you do put them on meds, both of them can decrease their longevity. So we just need to pay attention to all of these factors and variables. Chronic suicidal ideation is also a major concern with individuals with schizophrenia or schizoaffective disorder. Um, uh, I had forgotten this, but lithium has been shown to be protective against suicide, even at doses lower than the standard therapeutic recommendation. Now, lithium generally isn't one of my go-to medications in bipolar disorder, but we should consider that it does have this anti-suicidal effect. How many of you guys would have gone if this was a new case? Would anybody here have gone to lithium, or would you generally just go to a second generation antipsychotic? I guess nobody would fool with that lithium, and that's
I was
probably
told,
the point.
Dr. Brown, I was told or taught that if you have African American patients, that if there's anything else you could use to see if it would help before going to lithium would be the best option. Just due to Black patients having, increased, blood pressure and issues like that. So that's the way I was taught. So I always try to go to other things before I go
Uh-huh.
to lithium. So
Gotcha. Yeah, and that makes sense. That makes sense because it's renally excreted, and you got to think about kidneys and hypertension and sodium exchange. So yeah, lithium probably wouldn't be the top choice, and I would think in any person at this point. But it is the old and gold standard, and you know, actually, if you uh, lately it's having a comeback in Alzheimer's disease uh, with breaking up the plaques into tau protein in the brain, and it can actually improve the condition as opposed to just slowing it down. It's having a restorative effect. So lithium is on the comeback, but in this case here, I probably would just go with the second generation antipsychotics. Um, and then there's also the other mood stabilizers that can be employed. Um, Lamictal, Depakote, Keppra. In this case, treating the patient via telepsychiatry is an additional challenge. The establishment of a therapeutic alliance or rapport remains essential to all in a mental health care treatment setting. Studies have shown that patient satisfaction when treated via telehealth remains comparable and even greater uh, than the traditional face to face treatment. Uh, Telehealth increases access to care in underserved areas and has been shown to lower cost of providing care. So, um, in cases of paranoid schizophrenia, the establishment of a therapeutic alliance can be more difficult due to how the disorder can provoke suspicion and distrust. Interacting with a patient across a television monitor in a live video format can raise levels of distrust in a person with paranoia and accentuate their ideas of reference, such as the TV is talking to me. Thus, not all patients with schizophrenia or psychosis um, should be candidates for telepsychiatry. However, in this case study, the patient did not have significant impairment in his thought process, and he responded well to treatment via telepsychiatry. And that's just a side note, you know, where telemedicine can and cannot be useful. Um, I've only had a very few cases where the people really were having problems uh, with the television monitor and equipment. I want to just go over some real quick take home points before I open it back up for any discussion. Uh, Close out this discussion on schizoaffective disorder. Unlike patients with schizophrenia, patients with schizoaffective disorder have mood symptoms that occur during significant portions of their illness. Um, Once a very clear longitudinal history of symptoms and functioning is obtained, it is often possible to diagnose either bipolar disorder or schizophrenia in a patient with schizoaffective disorder. So, one of the first things when people are having a hodgepodge of psychosis, mania, depression, the thing to start is if the person's not a good historian, just get a caregiver and get a longitudinal history of when they were having symptoms and if they occurred together, the different symptom sets. Patients with schizoaffective disorder and manic mood symptoms should be treated with a mood stabilizer and an antipsychotic. So if they're schizoaffective, bipolar type, and are having mania, start with a mood stabilizer and an antipsychotic. Patients with schizoaffective disorder and depressive symptoms should be treated with an antipsychotic alone, and if this is not effective, then the antidepressant should also be added. So if the person's schizoaffective, depressed, and that's how they present, go ahead and treat the psychosis with an antipsychotic or treat the condition with an antipsychotic. Uh, and if that doesn't really work, and or the depressive mood symptoms, the depression symptoms persist, then go ahead and add the antidepressant. Uh, Younger patients with schizoaffective disorder generally exhibit more severe symptomatology than adults. So if the schizoaffective comes on earlier, it's a lot more intense than it is if it comes on as an adult. Uh, as opposed to schizophrenia and bipolar disorder with psychotic features, schizoaffective disorder patients must meet the criteria for major mood episode for the majority of the illness and have delusions or hallucinations for 2 or more weeks um, in the absence of a major mood episode. So they must have symptoms that occur together, and then when the symptoms abate, the delusions and the hallucinations must continue for at least 2 more weeks. Essentially, over the lifetime of the illness, the patient must present with just psychotic symptoms, no mood symptoms, for at least some time of the disorder, but at other times, both mood and psychotic symptoms run concurrent. All right. Does everybody get those pearls? Particularly how you initiate treatment if it's schizoaffective, bipolar type with mania, and schizoaffective depressive type um, with just a depression presenting with the psychosis. Any questions
Yes.
about what's that?
No, I
You
was just
got it?
saying yes. Got it.
Yep. Yeah. 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 Any questions anyone has, or any cases that anyone may have that may be similar to this, or they got other cases that providing you with some trouble? You need some feedback on from the group.
No.
All righty. Well, we had a lot of people on this case review. Does anybody have any other questions? Some of the people that didn't speak up.
What's the next topic going to be about, Dr. Brown? Next month.
Do y'all have something that's burning? Because I got a bunch of them. We can move to a child topic, or I just kind of picked this one since the last time we talked about mania with psychosis. So I figured I'd offset that with schizoaffective disorder. But is there anything y'all are interested in talking about?
Let's do a
For me,
child topic next time.
yes, kids
Adolescents.
and
What's that? I missed
kids
the
and
last
the kids
part.
and
Then
OB. What I'm interested in.
You said that the kids and what now?
Pediatrics and pregnant women. I mean pregnant
All
women.
right then. All right then. I will. All right. I'll see if I can pick either topic that involves pregnancy, like postpartum depression or something like that, or I'll pick a topic with some children. Okay.
All right. Thank you, Dr. Brown.
Thank
All right.
you.
Y'all take care. Y'all have a good month until
You
we
too.
talk to
Thank
each other again. All right. Bye bye.
thank
All
you.
right,
Thank
you
you.
too. Thank you.